Hello everybody, this is Dr. Shivam and you are watching my case representation of pancreatic cancer with severe jaundice complication. This case was observed in the Tata Memorial Hospital of India and supervised by the Department of Clinical Anatomy, Ternopil National Medical University. The doctor name is T.I. Karkula. Introduction of pancreatic cancer. Pancreatic cancer is also known as silent but deadly. Pancreatic carcinoma is a debilitating disease and carries poor prognosis, and that's why it's my favorite because it's rare cause of lower gastrointestinal bleeding, and this tumor behave very oftenly invade contagious organ, and symptoms are most vague, and this makes the diagnosis more difficult. So that most of the cases diagnosis in this stage of this disease. It is the 6% of all cancer-related death all over the world, and it is the 11th most commonly diagnosed cancer in men, 9th in women globally. There is only 5-year relative survival, only 8%. Luckily, there is lower risk in India. So, objectively, the study to undertake the review of the pancreatic cancer and elucidate the incidence, mortality, and risk factors globally, but with special emphasis with respect to the Indian population. Dietary habit, tobacco use, smoke and smokeless, or smokeless, and not sufficient physical activity will enhance the risk beside the associated factors. The case report. A 62-year-old female with a past medical history of essential hypertension presented to the emergency department with a chief complaint of black tarry stool, that is also known as melena. She noticed it 2 days prior to her emergency department presentation, and symptoms were not associated with abdomen pain, fatigue, or weight loss. Moreover, no significant risk like smoking, alcohol intake, family history of pancreatic cancer were reported upon her presentation. So the doctor thought it is just obstructive jaundice, and they gave the management of the obstructive jaundice, and that was ursodeoxycholic acid and amoxicillin 500 mg, chlorpromazine, NSAID as ibuprofen, and Evil. And this drug was given for the treatment because this drug was given for the treatment of jaundice. Later on, unfortunately, this drug did not relieve her from the symptoms, even from the disease. And after 6 months, the same patient come with the complaint of abdomen pain, weight loss, unintended weight loss, jaundice was consistent, bright red color stool, melena was present, and also dark color stool and itchy skin, blood clot in the stool, and the physical examination only jaundice was remarkable and others were normal. So doctor thought because it was jaundice treatment was given earlier but unable to treat, so doctor thought to do the routine checkup. In the first one, distal rectal examination, it was revealed there was black tarry stool with no palpable mass, so it has been confirmed that it is not anal fissure or some kinds of colon disorder. In the lab test, doctors get surprised because LFT was increased, liver function test was increased, and complete blood count, there was elevated thrombocytosis. It was earlier prognosis, but the most drastic change was from the elevation of serum amylase and serum lipase. Blood sugar is often elevated, and in this case was also elevated, but normally in case of jaundice it doesn't show any impact over the blood sugar level, but here it was increased. Thrombocytosis was observed, and elevation of both conjugated and total bilirubin was found. The next level, because doctors thought it may be tumor, so they run a serum test for the tumor marker with several factors, several standard markers, and there they found the CEA level was elevated, and that is known as carcinoembryogenic antigen, and CA125, CA19.9 level was tested, and later on there are given certain markers where the CEA on CA found. So as we can see in the colon cancer, hepatocellular carcinoma, and pancreatic cancer, and also in gastric cancer. So we can see here the major organ of the GIT is supposed to be cancerous if CEA or CA level is increased. Then doctors prescribe the next level, that is imaging. In imaging tests are usually primary method for the confirming the presence of mass of pancreas or any kind of tumor in the GIT. In the CT scan, it was observed that large head of pancreas mass causing a splenic vein thrombosis. We can see over here in the screen, and also it is this part, or here it is this part. Going to the endoscopic ultrasound, in the endoscopic ultrasound upper endoscopy procedure, what revealed the active bleeding gastric varices, no esophageal varices were found. And there was there was a conventional transcutaneous ultrasound is not usually done by the doctor because here the gas can make visualization of pancreas difficult. The next one was the endoscopic retrograde cholangiopancreatography, ERCP was done, and in the ERCP there was differentiate the disease from the other problems as such as pancreatitis, and it is also invasive procedure similar to the some of the tests described above. The next test was done MRI. In MRI, it was used to often actually used less often than CT in pancreatic cancer, but it may be used in certain circumstances because there are a special type of MRI including MR cholangiopancreatography, and in this we found out that there is bulging mass structure in the pancreas, and primarily in the people who's diagnosed with the unclear based of the other studies, or if a person has the allergy to the contrast dye used for the CT. The next one was the osteoscan. In the osteoscan, it was done, as we can see, a dye or known as tracer protein. Tracer was injected into the vein and the neuroendocrine tumor if present, so it is reflected in the scan. So when it was given to the patient, the outcome report, there was a radiation over the upper thoracic level and it confined the zone of the pancreas. The next is confirmatory diagnosis was done with the PT scan. In the PT scan combined with the CT, and it done to give the exact because here in this test a small amount of radioactive sugar is injected into the vein, and a scan is done after the sugar has had time to be absorbed by the cells, actively growing cells such as cancer cells, and it will light up in the contrast areas of normal cells or scar tissue. So here we can see the PT scan report, there was a lightening of that radioactive tracer which reflect that there is tumor growth. So the final confirmation of the diagnosis for the biopsy. A sample of the tissue is needed to confirm the diagnosis of most of the time, and in this case there are the type of biopsy could be seed of the tumor and the result in the spread of the cancer along in the line with the needle where the needle is introduced. Here is a fine needle biopsy, a procedure which is thin needle is directed through the skin in the abdomen into the pancreas to extract a sample of tissue, and this most often done using guidance with the either ultrasound or CT scan. Differential diagnosis, because it is very important once you get confirmed with the pancreatic cancer, but to avoid the risk or future problem, we differentiate from other similar complaint containing disease. In this case, there is bile duct stricture, acute or chronic pancreatitis where inflammation is supposed to be differentiated, bile duct stone, ampullary carcinoma, bladder cancer, gallbladder cancer, gallstone, gastric and duodenal ulcer, abdominal aortic aneurysm, pancreatic lymphoma, gastric lymphoma, liver cancer, and bile duct cancer. The final stage of tumor marking. Determining the stage of pancreatic cancer, it is extremely important when it comes to the deciding whether the cancer is being surgically removed or not. If the staging is inaccurate, it may lead to the unnecessary surgery, and staging can also assist in estimating prognosis of the disease. Moreover, while going through this kind of examination, most of the time stage 4 is found, which is there is 100% chance of doing surgery. This surgery is known as T and M staging, where T stands for the tumor, N stand for the lymph node, and M stand for the metastasis. There are basically 4 subdivisions of T, that is T1, tumor confined to the pancreas and less than 2 cm, it is the first. T2, where the tumor is confined to the pancreas with more than 2 cm. T3, extend beyond the pancreas, duodenum, bile duct or mesenteric vein is affected. Or T4, the last stage, most severe, where the tumor involves the celiac artery and superior mesenteric artery. Later, going on based on T and M, the tumor are given stage from 0 to 4, total 5 stages. In the first stage, stage 0 is also referred to as carcinoma in situ. Their cancer not yet spread past something called the basement membrane. In stage 2, their pancreatic cancer is confined to the pancreas or less than 4 cm. In previous one is stage 1, and the stage 2, their tumor either extend beyond the pancreas without involving the celiac axis. Stage 3, where extend beyond the pancreas and involve the celiac artery and superior mesenteric artery. Stage 4, where it can be any size, while it may or may not be spread to the lymph node, but they have also spread to the distant side of the liver, peritoneum, and also sometimes abdomen cavity and bone and lungs. Pain assessment and management in case of pancreatic cancer. There is my small effort to tell the anatomical location which is supposed to be responsible for the particular type of pain. It is just a hypothesis, not a practically 100% accurate. Just we can see that the tail part of the pancreas give the most of the symptom. So most common cause of the pancreatic cancer, most common anatomical location is the tail part of the pancreas, but if you go to the severe stage, body is affected and head. Here a pancreatic cancer stage, we can and they're confined that it is pancreatic cancer over the tail part. Is mostly found elderly stage. Cirrhosis is the next level. Fatigue patient feel. Hormone therapy if he is taking. Smoking may cause. Weight loss symptom. Alcoholism. Diabetic mellitus. Biopsy. Internal bleeding. Loss of appetite. Fever. Virotherapy. Endoscopy. Radiation therapy. Diagnostic sonography. MRI and chemotherapy. The last one is surgery. Treatment. Treatment of pancreatic carcinoma is conventional procedures such as VPUL involve the removing of the head of pancreas, the first part of the small intestine, and the gallbladder and bile duct. However, only 20% of pancreatic cancer patients are referred to this risky procedure, because you can see here gallbladder, bile duct, small intestine and pancreas, all 4 organs part are supposed to be removed. Other procedure includes the total pancreectomy, removal of pancreas, or distal pancreectomy, removal of pancreas and spleen. The most patients are diagnosed with the cancer only after multiple tests such as MRI, CT scan, ERCP, etc. So here the good news is that the dramatic transformation in the field of oncology, patients who now have access to the minimal invasive procedure to detect as well as treat the cancer in the pancreas at the early stage. For instance, procedure is known as cholangioscopy, which allows the direct visualization of the biliary and pancreatic duct. Combining cholangioscopy with the endoscopic ultrasound helps a gastrointestinologist to have a clear understanding of the pancreatic duct. The procedure entails using a small endoscope called the cholangioscope, passing it down to the esophagus into the biliary tract, and the colonoscope comes with a tiny 1 millimeter HD vision camera and facilitating the gastrointestinologist to diagnose, take tissue sample, and prepare a further course of the treatment. It is a vital diagnosis tool for the confirming as well as ruling out the pancreatic cancer. The minimal invasive procedure also helps target the spread of cancer surrounding our organ without undergoing complex biopsies. Pancreatic cancer is a major health concern and is rapidly growing at an alarming rate. It's time to give impetus to raising awareness about the medical condition and possibly therapeutic solution, and timely detection and early referral are essential in managing the pancreatic disease and burden. Here is my last observation of the discussion in India and USA. Pancreatic cancer is commonly seen in the elderly population, the fourth most common cause of cancer-related death in the United States. Unfortunately, less than 20% of people present with a localized, otherwise it is generalized, potentially curable tumor with high annual incidence of mortality, 5-year of survival rate only, or less than 5. The most patients dying within the 2 year of diagnosis. Our patient's lower gastrointestinal bleeding was due gastric variceal bleeding from the splenic and vein occlusion by the pancreatic mass. Here is the Tata Memorial Hospital result from 1987 to 2007. We can see there is drastic increase in the male and female, both the case of pancreatic cancer. The HBCR report around the India 2016 revealed city-wise there is death caused by the pancreatic cancer. In West Chandigarh and Trivandrum and Mumbai, 3 top countries who are suffering from the pancreatic cancer because of poor diet. In America, similarly, American blacks are most sufferer, and in all American, it is supposed to be higher rate. The city-wise location and their distribution are given in the chart. So understanding the clinical sides of the disease, the pancreas is an extremely delicate pear-shaped organ divided into 3 main parts: head, neck, body and tail. The producing the digestive juice that flow into the digestive tract. The juice helps to digest the partially digested food by the stomach. The body and the tail of the organ produce insulin that helps to control the blood sugar level. The pancreas therefore becomes immensely essential for the better digestion and absorption of food in a human being. The disease began with no known reason, and scientists to date have not been able to pinpoint the culprit. However, lifestyle factors such as smoking, drinking, obesity, and other can trigger as well as increase the chance of developing cancer in the pancreas. One of the reasons why most patients are diagnosed only in the later stage of pancreas is because of the location of the organ. Since the pancreas is located in the posterior part of body, early tumor does not show any visible symptom, and it is only when the tumor starts spreading and affecting the organ that the patients being the demonstrate symptom. And some of the commonly observed signs of the cancer are new onset of diabetes, jaundice, sudden weight loss, itching of the skin. The conclusion of all this presentation, it is important for the clinician to keep pancreatic cancer in the differential diagnosis in the patients presenting with melanoma. Here are my 8 cases which I studied, various age factors. They are almost 50-year age group, and their gender are also mentioned here. Their uncommon presentation, you will find that there is melanoma, hemorrhage or blood is present. The final diagnosis was the pancreas or splenic. There was combined, and their treatment was supposed to be surgery, surgery, and palliative therapy, surgery, chemotherapy. Unfortunately, only few students were having survived rate. They are my references which I used to create this presentation, and hope you guys liked this video and my case presentation over the pancreatic cancer. Thank you.